All right. Good evening, everybody. My name is Dr. Siobhan Statuta, and it gives me great pleasure to be able to join you guys tonight. And thank you guys for joining into the AMSSM National Fellow Online Lecture Series. Tonight, we're really excited about our speaker, Dr. Leggit. But before we get to that introduction, I'd like to just take a step back and talk to you a little bit about this National Fellow Online Lecture Series. It is sponsored by the AMSSM Education Committee and the Fellowship Committee in conjunction. Okay, so the purpose of these talks is to serve as an adjunct to your individual program's educational programming. It's also to provide fellows with direct access to educational experiences with top AMSSM members in a variety of formats. It's also to assist in CAQ exam preparation. As I just took my recertification, trust me guys, this is really valuable information. So I'm excited to be able to offer this to you. So just a couple of things to keep in mind. Please mute your device's microphones. You can submit questions through the chat function, and that's going to be my job. And just include your name and program if you wish, but just write down the questions, and then at the end of the talk, I'll do my best to address all of these and have Dr. Leggit address your questions. The moderator, myself, will ask these questions during the Q&A based on the questions you submit, and then after the program, you'll be seeing in the chat function a link to an evaluation, which will be available also on AMSSM Collaborate after the talk. So without further ado, I'm super excited to introduce you guys to our speaker tonight. We're going to be learning all about anterior knee pain from Dr. Jeff Leggit. He serves as professor of the departments of family medicine and physical medicine and rehabilitation. He serves as vice chair at the Department of Family Medicine, as well as director of the University Family Health Center at the Uniformed Services University of Health Sciences. Dr. Leggit earned his medical degree from the Uniformed Services University and completed his family medicine residency at DeWitt Army Community Hospital, located in Fort Belvoir in Northern Virginia. He's a retired Army colonel with more than 25 years of active service in a variety of capacities and was awarded the Bronze Star Medal in Operation Iraqi Freedom. An award-winning active educator, researcher, and clinician, Dr. Leggit is a board-certified family physician with a certificate of added qualifications in sports medicine. He is vice chair of the family medicine department and is the clinical musculoskeletal director for the School of Medicine. Now, in addition to all that, he's a key faculty member for the National Capital Consortium's Military Primary Care Sports Medicine Fellowship. So he does not have a lot of downtime, ladies and gentlemen, but he has agreed to join us tonight to teach us about anterior knee pain. So without any further ado, I'm going to turn it over to Dr. Leggit.
Thank you much for that introduction. I also took my recert in July, and so I hope that this prepares you. I almost guarantee there'll be a couple questions on anterior knee pain. So without further ado, let's go ahead and drive on. I have no financial interest or relationships to disclose, and I'll let you take a look at this question, and hopefully by the end of the talk, you'll be able to answer this. So what is the most appropriate next steps for a patient you diagnose with patellofemoral pain syndrome? I'll let you look at those choices. With that, this will be our outline. We'll talk about the definition of patellofemoral pain, its differential, how to assess it, and how to manage it. And then barring enough time, we'll also discuss Pleika Syndrome, which is certainly one of the differentials in there. And in addition, infrapatellar fat pad syndrome or Hoffman's fat pad. So what is the patellofemoral joint? Well, it's the articulation between the patella and the trochlear groove of the femur. And it is the largest sesamoid bone in the body. And just as a reminder, sesamoid bone is embedded within inside of a tendon and is embedded inside the quadricep tendon. Its main job is to increase the quadricep movement arm. And in addition, it provides bony protection to the distal femoral joints when the knee is flexed. In addition to those bony constraints, there are soft tissue stabilizers that we need to be aware of. And you can see here retinacular structures on both the medial and lateral aspect. And then there's ligaments, both a lateral patellofemoral ligament and an all-important medial patellofemoral ligament, which is important when you have a lateral patellar dislocation that MPFL leads to tear. And there is also patellatibial ligament, both in the medial and lateral side. And this is a cadaveric section of both those. And on the lateral aspect, you can appreciate the retinaculum here. And on the medial aspect, that retinaculum is removed, but you get a good look at the MPFL and the MPTL. And so you need to be aware of these soft tissue stabilizers and the role that they play in the patellofemoral pain syndrome. So sports medicine encounter begins with a good history, and obviously you need to take the chief complaint. And then what is the antecedent event? Is it some sort of trauma or is it a repetitive activity? You need to make sure you take a good training schedule, but I'd implore you to also ask about the occupational workload, and that becomes really paramount when we deal with service members, because in addition to their sporting activity, their workload obviously puts a strain on their body too. And that goes along with other members of society. And again, take a good history of a shoe life. The rule of thumb is, every year or so you need to change your shoes, and every 300 to 500 miles. Obviously, there's more into that depending on what type of striker you are and what kind of terrain you're running into, but you need to take a good shoe life history. And then you want to know if they've injured this area before, and if they have, what are the therapies that they've attempted? And when you ask about the therapies and they discuss physical therapy, you need to really ask them what they've been doing. And if they can't demonstrate those exercises, then it's probably likely that they're actually not doing those exercises. And then if they tell you they've had an injection, you need to actually know what it was and what the material was injected. So you need to know those therapies, and if they worked, you might repeat those, or if they didn't, those would be something you wouldn't try again. And remember that we're all physicians, and so there are medical conditions, autoimmune infections, malignancies that can masquerade as MSK symptoms. So don't forget to do a good review of symptoms. And then ultimately, what is their goal, both occupation and treatment-wise? What are they hoping to get to? And that will help guide your therapy. So with that in mind, let's talk a little bit more about patellofemoral pain. So again, it's abnormal stress underneath the kneecap, but from what? Abnormal tracking is kind of what we say, but is that exactly true? And after this talk, I hope you can help me answer that. It's quite common, and so probably 25% of all knee injuries are patellofemoral pain. About 11% of all MSK complaints will be from there. Very common in runners. Unfortunately, in my world, it's probably the most common reason for failing military basic training. And it's really going to be diagnosed under clinical symptoms, and we'll harp on that over and over again. It's this diffuse anterior knee pain, worse with any loading of that patellofemoral joint. And that's probably the best symptom that we can have. We'll talk about some physical exam findings, but really this loading of the patellofemoral joint is probably the best way to make the diagnosis. In the old days, we would talk about a theater sign, but hardly any of us go to the movies for numerous reasons. But if you can't really sit for an hour or so without having to move your knee around, that would be an old theater sign. Some of the patients can have this giving way phenomena, which what that is as they have pain, their muscle gets inhibited and it feels like their knee gives way. It's not a dislocation, but it's just the muscle being inhibited because of pain. And I can't emphasize this enough, swelling generally needs to be absent. And in fact, if there's swelling present, you need to think of other disease processes that could be causing this. And we used to think that a traumatic history made it unlikely of patellofemoral pain, but that turns out that's not necessarily true. And it can often be the inciting event and can start the cascade of events. And there's about a 2-to-1 female predominance for patellofemoral pain. So with that, this should be our working diagnosis. Patellofemoral pain syndrome is defined as anterior knee pain in the absence of any other pathologic condition. So that means our job is to rule out any other pathologic condition, and there's quite a few of them, and we'll spend the bulk of our time talking about that. Unfortunately, the cause is multifactorial. If there's only one thing, it would be easier to fix, but there's lots of different factors that can lead to this. You have to ask yourself, is there a long-term sequelae such as arthritis? And the answer is maybe. The verdict's out on that. We're not exactly sure about that. Again, it affects probably about 23% of the adults. At one point, we didn't used to think it affected children, but that's not necessarily true. So about 29% of adolescents get this. I said it was predominant in runners, but cyclists can also get this. And unfortunately, 20 years later, up to 50% of people are still affected. Now, that may have been some old studies, and we're hoping now that we have better categories and better ways to treat people that we can kind of change this. And that's my hope after this talk, too. So I'll be referring to this International Patellofemoral Pain Research group, and this is their fourth one. We'll mention their fifth one. They had the sixth one in 2019. They've yet to publish the results that I've seen, but we'll refer back to them every so often. And so what they found is the preferred term is the patellofemoral pain. And again, as we talked about, it's defined as pain behind the patella, aggravated by any patellar loading. Again, remember, our job is to rule out other things. So you can have no history of subluxation or dislocation. That would be a different diagnosis. And again, pain with squatting is probably your best test. That's probably 80% accurate. And like I mentioned before, it's common in adolescence. And unfortunately, there can be many factors that alter the mechanics of the patellofemoral joint, and they can increase joint stress, and they may lead to patellofemoral arthritis. Remember, I said the verdict's kind of out on that. And this is why I mentioned that we may be talking about Hoffa's fat pad, because it's intracapsular but extrasynovial, but it's highly innervated, and it can be a potential or a cause of anterior knee pain. And one of the questions is, does it lead to patellofemoral pain syndrome, or does patellofemoral pain syndrome lead to, Hoffa's fat pad? And so we'll be discussing that a little bit. And by far and away, a combination intervention is recommended, and that would be one that you'd want to remember for the CAQs. And we recommend that researchers use patient-related measures, and they state what those are, so that we can compare and contrast our research. So the way that I think about patellofemoral pain syndrome, my differential, is conditions that have malalignment or conditions that don't have malalignment. And I know this is, can be intimidating, but to me, this kind of helps. And so we're going to talk about these conditions that present with a malalignment, and then the ones that don't have a malalignment. And so we'll discuss those a little bit further. Another way, if you don't like that list, is this comes from up to date, and you could think, is it primary bone pathology? Is it from the synovium? Is it retinacular? Is it more bursa related? Or there's nerves? In saphenous neuritis is one that we need to worry about. And those would be folks that are kind of sitting on like a surfboard or a horseback rider, and so they're kind of pinching that inside of the nerve, the medial aspect, and that could irritate the saphenous nerve. Again, could it just be a tendinopathy, a quadriceps or patella? And then don't forget referred pain. And I will also add that, again, there could be other diagnoses. That's why we need to do a good review of systems on there. So let's talk about the physical exam. Really, you're not going to find a lot of things that tell you it's patellofemoral pain syndrome. You're looking for other etiologies or modifiable factors. So with that, everyone needs to be in shorts. Everyone needs to have their socks and shoes off, and you're going to be looking for foot structure. And let's go into that a little bit deeper. And so you're going to want to do both a static and a dynamic exam, and you're looking for both hypomobile or hypermobile. And these are kind of ends of the extreme. And so this would be an overpronated foot, and this would be an oversupinated foot. And obviously there's exaggerations of these, but these are in static exam. And then after you do that, you need to do a dynamic exam. For this patient up here, we have the pes planus. Now, someone who had a flexible flat foot, when they stepped on their toes, they would recreate the arches you see here. Or as you see on this right foot, that they have a fixed defect. And in addition, they do not have good calcaneus varus movement. And so hence the reason why you need to do both a static and a dynamic exam on that. And again, you're also looking for pes cavage, which you can think of as a kind of rigid, inflexible foot. And one of the things I want you to remember or think about is when you have any of these fixed defects that we talk over here, you need to consider, is there a structural abnormality or neurologic disorder in something like hereditary motor sensory neuropathy, or the old term Charcot-Marie tooth need to come to mind if you have fixed defect. So go back to our physical exam. After we looked at their feet, you're going to want to look at their lower extremity, both for malalignments and leg length abnormalities. And let's dive into that a little bit more. And so of course you're going to look for the, genuvarum or the bowed Leggit or the genuvalgum knock-kneed. But in addition, don't forget about the recurvatum. And when you see someone who has this, we think of hypermobility syndromes on there. And don't forget, you might need to do something called a Baton score. And if you're unsure what that is, look that up. But we're looking for clues of why this person may have that. And so this is a sign of maybe hypermobility. And then we're going to talk about our malalignments a little bit more. And so in this patient, they probably have some femoral anteversion and some tibial torsion. And what can happen with that is you can see that the patella is really offset over the lateral femoral condyle. So that's why that's important to look at. It would be quite difficult to fix that just with physical therapy or strengthening. And this may be something that they're going to always sort of have that, or it's something you might discuss with the surgeons. So going back to our malalignments, I would encourage you to look for leg length discrepancy. There's something we call functional and true. A functional is measured from the umbilicus down to a point in the medial malleolus. And a true is from a fixed bony point to a fixed bony point. So normally we'll say the ASIS down to the medial malleolus. If you think someone has a true leg length discrepancy, then you must get a scanogram. Our x-rays actually measure that. And by convention, we usually say if it's a centimeter or more, then that is actually a true leg length discrepancy. And that's something that you're going to want to try to address. In the old days, we used to talk about the Q angle, but it turns out really a dynamic exam is better. And so one of the things that you should be doing in your office is a single leg squat. And this is an example of a good single leg squat. And this is an example of a bad single leg squat. And these are all the things that you're going to need to correct to help this person with their knee pain. Or step down, where she steps down here and she's able to maintain good alignment. This would be an example of bad alignment. And so we need to find out what that's from. Is that from, a muscle weakness or some malalignment? But this is something we'd want to correct on there. The reasons we do that is depending on the angle of flexion that you see here, there's different stresses on the femoral trochlea and on the patella. And then you can see the increased body weight as we go down to squatting. And 20 times body weight is quite a bit, which is why that's probably one of the best signs or symptoms to be looking for when we're trying to figure out patellofemoral pain syndrome. And then, of course, you need to take a look for hip strength with the Trendelenburg sign here. So going back to our physical exam, we've looked at their foot, we've looked at malalignments, we've looked for leg abnormality. You're going to want to measure quad size or strength, looking for any gross atrophy. And again, just looking at it isn't the best exam, but again, you can get a sense if they have atrophy or not. The traditional test that we teach, and I teach this in our first year med students, is patellar grind, where you're directly pushing down the patella and you're trying to force the patella into the femoral trochlea. Or the quad flexion test or the Clark test, where you fix the quadricep tendon and ask the patient to flex their quads. It does the same thing. You're trying to force the patella into the trochlea. And so those are some of the exams that we talk about, but they don't have really great sensitivity or specificity. So just bear that in mind. Then one of the other things you'll need to do is patellar tracking, where we're looking for lateral movement. And then something that's called a J sign, and here's an example of that, and we'll talk about the J sign a little bit more. And so in the J sign, you take your patient from extension to flexion, and they may have this abrupt jump that looks like a J, and you can see this in this cartoon where the patella actually slides off laterally. And we're supposed to try to grade that by how many quadrants it moves, 25%, 50%, 75%. It turns out that a recent study showed that there really is poor intra-observer reliability. And even if you do see this, it's more than just this lateral movement. It's really a complex abnormality. I will tell you, though, that if you've ever seen a J sign, you'll never forget it. But it may oversimplify the process. And even if you don't see it, it doesn't mean there's not some tracking abnormalities that are happening. So going back to our physical exam, then the other thing we want to talk about is patellar glide and tilt. And so when we talk about glide or tracking, we actually try to move the patella both medially and laterally. And normal is under 50% without any apprehension, meaning the patient doesn't complain about it. And you need to do this in about 20 degrees of flexion, so you kind of unlock the knee. And so that's what the glide would be. But let's talk about tilt a little bit more, which is a measure of retinacular flexibility. For me, what I kind of teach the med students and residents and fellows is the patella should move some, but not too much. And when you do a bunch of exams, you're going to know when it doesn't move or when it seems to move too much. And unfortunately, different people use different terms for tilt, but let's talk about that a little bit. So what you're doing is you're moving the kneecap laterally. And normally there should be 25 to 50% movement in the lateral portion. And then it may have a little tilt to try to get above this lateral femoral condyle. And up to 15 degrees is considered normal. This would be abnormal. If it points down or it picks up and points down, those are abnormal tilts. And then this is a graphic of one of the ways we measure tilt, where we actually draw a line through the patella and a line over the bottom of the femur, and we measure that angle. And so that kind of gives you an idea of some of the things we're looking for with patellar glide and tilt. But again, remember this axiom, it needs to move a little bit, but not too much. So going back to our physical exam, you need to do a good hip abductor and external rotators for both their flexibility and strength. And this is where working with an athletic trainer or physical therapist can really help, so you can get some objective data, such as a dynamometer data. And then the presence of a plica you're going to be looking for. If you have not felt one, I promise you, you'll know it when you feel it. But those would be the plicas that are not underneath the actual kneecap itself and that are actually outside of it. But I promise you, you'll know it when you feel a plica. And then at some point, somebody needs to do a good exam of knee stability and the meniscus. And I've had a handful of PCLs that were missed over time that are just attributed to diffuse anterior knee pain. And so somebody needs to do a good knee exam. And then you'll need to do a gait analysis, whether that's informal in your office or it's a formal one where you put them on a treadmill or track and measure it, but you'll need to kind of watch them both walk and run. And so again, this is your physical exam, and you're really looking for other factors that you try to correct or other disease entities. And so then the question is, do we need to get radiographs? And I both do family medicine and then I do sports medicine. And when I do sports medicine, I'm really a consultant, and I think I have a higher onus. And when I'm in my family medicine hat, I may not order x-rays right away. I will tell you, as a sports med doc, we probably need to be ordering radiographs, or certainly if someone's not responding to your treatment. When you do order x-rays, you need to know what to order, and we need to order, of course, the APM lateral, but then there's some special views that you need to order. And those special views would include a sunrise and merchant view. And a sunrise view is, pretty well flexed, and the merchant view is about 60 degrees of flexion. And you're trying to look down the trochlea to see if you have a dysplasia trochlea like we have here. I realize these are static views, and there are now dynamic CTs and dynamic MRIs where we actually see the patella as it moves all the way through flexion extension. And as those become a little less cost prohibitive and a little easier to do, that may be something we're doing a little bit more often. And then I need you to look at your x-rays, because we'll be looking at things for Alta and Baja, which we're going to talk about a little bit more. But again, you're also looking to rule out arthritis or osteochondral defects, and we'll mention those in a bit. So one of the other things you want to look for is bipartite patella or patelli. And most of the time these are asymptomatic, but they certainly can be symptomatic. You need to be aware of that. And so, and in addition, these are some questions that may be asked in your CAQ. And so type 3 is the most common, and this is a type 3 variety right here. And then there's type 2, which is the next most common, and these are x-rays of type 2 and 3. And again, you can have tripartite patellas, and you need to be aware of those. I will tell you that you will be able to figure this out by both careful physical exam, and then that might be the use of your judicious diagnostic injection to see if that's the source of pain. And so again, so be aware of the bipartite patella. And then I need you to consider patella baja and alta, and certainly alta is much more common than baja. Unfortunately, there's a few different ways to measure this. I use these two up here. Probably the one that you need to measure is the one that your attending wants, or the one that your orthopedic colleague wants to use. And so be aware of that. There are different mechanisms, ways to measure it on there. Now, I also encourage you to look at your own films. And this was an adolescent that presented with knee pain, and the radiologist did not call it patella alta and also didn't comment on one of the abnormalities. And so there's patella alta on both these x-rays. This one is more predominant, but also they did not call this ossification center here, which is Sidney and Larson Johansson, which is akin to Osgood-Schlatter. And so you need to get in the habit of kind of looking at your own x-rays, not to second guess anybody, but things are missed and you're the one who examined the patient and kind of know what you're looking for there. And so you will know a dysplastic trochlea. Certainly these are kind of very obvious. The shallow trochlea can be a little bit subtle on there, but as you do more, you'll kind of get used to looking at that. And the reason to do that is this may be somebody who would benefit from seeing your surgical colleagues. And so these are two different patients, pre-surgical, and you can see there's really kind of no trochlea here. And then they had a trochlea that was carved out for them, and they went on to improve on there. And so that's somebody that you may want to refer to your orthopedic surgeon because they had a dysplastic trochlea on there. The other thing that you may not measure all the time, but I want you to be aware of that, is something called the tibial tuberosity to tibial groove sulcus or distance. And what it is a measurement of, here's the tibial tuberosity, and then here's the tibial groove, and it's a distance in between here. And greater than 20 millimeters is considered abnormal. And this is a patient that would have that, and this is obviously a gross exaggeration, but she would need to, if she wanted to continue to be an athletic or not have pain, she would need to have surgery to do that. And so there are a subset of patients that present with anterior knee pain that probably surgery is their best treatment. So I want you to be aware of that concept. And then of course you're looking for osteochondral defects, and then cartilage defects or condyle defects. Now I don't think you need to get an MRI in everybody. This was a patient of mine, and something in his story was a little bit different. He had a traumatic history that started everything about a year or so ago, and I suspected that there was, more of a traumatic origin, and that's why I ordered him. So again, the reason to take a good history. So again, I'm not advocating you need to get an MRI on every patient, but just consider that with your history on that. So we've taken our history, we've done our physical exam, and then this is our diagnosis. Again, they need to have the characteristic history, presence of retropatellar or patellar pain, reproduction of that pain with functional activities such as squatting or climbing stairs. And then again, our job is to exclude every other condition. So we feel comfortable that we're dealing with patellofemoral pain syndrome at this point. So with that, I'll let you take a look at this question and then see if we can answer that. And this is quite similar to a CAQ question. So a 42-year-old female complains of worsening anterior knee pain since training for an upcoming half marathon. She denies any overt swelling or effusion, instability, or locking of the knee. Her triggers include climbing stairs. Which of the following is true regarding this condition? Is it called chondromalacia? Is she guaranteed to get joint arthritis? Does dynamic valgus promote patellofemoral pain syndrome, or is a static Q angle the greatest contributor to this condition? And hopefully you chose dynamic valgus. Chondromalacia patella is really either a surgical diagnosis or advanced imaging diagnosis, meaning it's a softening of the cartilage. And again, we are unsure about patellofemoral joint arthritis. We said this is actually one of our physical exam things, and we said that predisposes someone to this. And again, we really don't do the static exams anymore. We do the dynamic exam, which is why C is the correct answer. And so this CPG that came out in 2019 is where these categories have come out of, and we're going to talk about that. And this really has kind of changed the way I treat patellofemoral pain syndrome. I kind of just threw everything at patients, and now I'm a little bit more selective on there. And so is the history of solid overuse one, in which case the first intervention may just to be to take it easy and do some load management on that. So is there a clear overuse history? In fact, I just saw someone in the clinic yesterday that she's training for a physical therapy or physical fitness test for the Army. She's doing the service, and she's been running a lot more than she ever has run before. And so, we need to shut her down for a little bit. Or does your exam show muscle performance deficit? So is there notable weakness in knee and hip extension? In which case, that's what you're going to target treatment for. Or when you have them do some movement, do you see some dynamic abnormalities that need to be fixed? And then you need to work on that. Now, is that movement disorder because they're weak, or they just have a problem that you need to try to work with on the gait analysis? But you would structure your treatment for that. Or do they have some mobility impairments, such as a hypermobile foot or hypomobile hamstring or quadriceps or even patelloretinaculum they need to work with? This may be where you put a foot insert, or that you work on some stretching or flexibility on that. So again, I would encourage you to start using these 4 groups. Unfortunately, it can be a combination of any of these, and so that patient I told you about before that had the overtraining, she also has quite a bit of movement coordination deficits, so we're going to work on all those together. So with that, what's the best treatment for each group? Well, there's some other factors you need to think about. And so it's not just the biological, it's the social and psychological. I was going to put that patient on a profile, which means that she is not required to do physical training, but mentally she didn't want that because she's just trying to cohese with her group right now. And so you need to think about that. And then don't forget about a kinesiophobia. I know that's really come out in the ACL literature, but that could be, with any pain type of syndrome. So you got to take these in mind too when you're treating your patients on that. So remember I mentioned that International Patellofemoral Pain Research Group. So now we'll go over their 2018 statement on therapies that we need to use. And so here's their 6 recommendations. Exercise therapy is really recommended for both the short, medium, and long term, and it improves function both in the medium and long term. Not maybe the short term, which is the other thing, is your rehab is not instantaneous. I usually tell folks it takes at least 6 to 8 weeks, for it to see some improvement on there. And then this is another thing that you need to take to heart, that both hip and knee exercises are recommended, and this combo should be used of just any alone, or for sure just knee exercises alone. And then you should consider adding foot exercises or intrinsic foot exercises to that. And we often recommend that to do that, and that could be simply just curling your feet up, or trying to curl a towel up, or trying to work on your arch. And then again, we already said this, combined interventions are the best. And prefabricated foot orthoses are worth a try, and they can help in the short term, and we'll talk about that a little bit more. And that mobilization is probably not recommended, and TENS units probably aren't recommended. I'm not sure that they will do harm, but they haven't really borne themselves out in study that they're really going to do a lot of help. And so we're going to go over this in a little bit of detail, so I don't want this to be overwhelming, but remember, you're going to fix any problems noted on exam. This sounds easier said than done, but if you can get some weight loss, that would be helpful, but obviously if they can't run, it might be difficult. We talked about strengthening, so let's talk about that a little bit more. And so you may have heard these terms open chain and closed chain, and what are those? Well, open chain is you're not connected to the ground or to a fixed object the whole time. And closed chain is you're connected to a solid object, the ground if you're doing lower extremity stuff, and if you're doing upper extremity, you're kind of touching the wall. And so what's the best? And people debate about that. And for me, the bottom line is your functional tasks are all closed chain. So if you start with open chain, I really don't have a problem with that, but you're eventually going to have to do things closed chain, because that's what your functional tasks are. And people debate, again, what's the best, but again, ultimately you're going to have to do closed chain. And then what do you exercise? Do you just work the VMOs or all quads? Yeah, all quads. And then don't forget that once you build strength up here, you need to challenge the neuromuscular system and the proprioception system, so that you can help with that too. And so once that she's strong here, we're going to get an unstable platform to start working on neuromuscular proprioception. And then everything you do for the knee, you got to do for the hip as well. So that's on what we would do for strengthening. And then again, we talked about quads and hips. I'll get back to flexibility in a little bit. What is the role of bracing or taping? And let's talk about that a little bit more. And so there's a variety of ways to do taping. And again, depending on what you want to do, there's different taping techniques, and this is an example of those. If you haven't learned taping, I would encourage you to do trial and error, to work with your athletic trainer or physical therapist to learn some, or even to have patients experiment with themselves. But what's the evidence show? Well, it shows that tailored patellar taping is effective for short-term relief. So remember I said rehab may take 6 to 8 weeks. Well, taping may help them with some pain relief in the short term. And so that's something that they can do. And it's pretty easy and low tech. And in that vein, I also think bracing is kind of worth a try, but it's not universally agreed upon. And so For me, I tried on some patients. As long as they're doing their strengthening, I'm okay with it. And what brace do you do? A little bit of trial and error. I actually prefer the Chopat, but again, that's not super evidence-based, but it's certainly worth a try. And as long as you're doing the rehab, I personally don't have a problem with that at all. Now let's talk about foot inserts. And so this is an interesting study. And so they had 220 patients and they randomized them, regardless of what their exam was, to foot inserts or hip exercises. And what they found was 48% got better with the foot inserts, 50% got better with the hip exercises. When they decided to combine them, all did better, but they couldn't predict who would do well, regardless of their physical exam on there, which is why you need to make sure strength is good. And I think foot inserts is worth a try, and they can be over the counter. And for me, I'll give them in the office and have them try a squat and see if that helps, or let them try them for a week or so. If it gives them relief, then that's something I'm going to use. And again, over the counter is acceptable, or at least to start before you move on to the custom inserts. And so that was bracing and taping. And then training errors you're going to try to fix. And so gait retraining is certainly something that's very viable, may not be something you have ready available. And one of the things sometimes it's hard to retain. And so one of the easiest ways to do gait retraining is to increase the cadence rate. And this study that's fairly recent came out and changing just by 10%. So if you're like at 160 or 165, you move your cadence up to 180 something. And that's pretty easy to do with either an app or a metronome, or some music. And look at the new, pain scale dropping down, 6.5 down to under 2 and sustain. And then on this lower extremity functional scale, well, the higher is better. Look at those scores on there. And so this is an easy thing to do. And I'm not saying formal gait analysis and formal gait retraining is bad. I'm saying this is something that you can do in addition to that. And so that's certainly worth a try. And then what are the roles of medications on there? And for me, the way I do medications is if you're unable to sleep or work or do your rehab, then I need to help you do that with pain, to help pain, and medications are the way, one of the ways I do that. Or if I've kind of plateaued and I need to help. And so, because oral NSAIDs or topical NSAIDs aren't going to fix anything. But again, if you can't contribute to your rehab or you're unable to sleep, we need to help with that. And how about injections? And so the question is, what's the target? And I've done, not tons of injections for patellofemoral pain syndrome, but I've done some. So what's your target? And if you think the vasosaturalis is pulling the patella too much, some people consider de-innervating that with some botulism toxin. I would suggest that you try a trial of lidocaine first and then have them run and see if that helps. Are you going to try and inject in the patellofemoral joint? Now this is where I've done a fair amount more diagnostically to see if that is the source of my pain. Know that there's very limited evidence for all of this. I've done it before, but again, there's limited evidence for any of the injections. And then again, surgery for only clearly defined problems. And so for that dysplastic trochlea, or for that person who had the tibial tuberosity that was really wide compared to a tibial groove, those would be somebody that you would do surgery for. And so stretching really in isolation is not truly that helpful unless you found that there was a pathologic restriction on the quads and hips. So, with that, I'll leave it at that. And then probably the other thing is education on load management. And then let's talk about that a little bit more. And this is a nice pictorial graph of education and then exercises on both the hips and core and knee, and then some gait retraining. And so they were randomized to all three of these. And what they found is, although they got some more strength back and had better running mechanics, none of them did any better than the other ones. And education was just as good in the long run for their symptoms or functional limitations on there. And then one other study that I want to discuss is this activity modification in adolescents. And what they did is they incorporated kind of everything that we would do as a sports doc. Is we would do load management, gait analysis, and education. And they gave them this scale of pain. If your pain was, above here, you needed to back off. And so that was their load management. And this is real critical here. At 12 weeks, quite a few completed the study, and then 86% reported some success or reported success. And that was retained at 80% at 12 months. And so this is really more akin to what we would do as physicians, is we would educate them on load management, fix some abnormalities, you saw. And if you do that, hopefully you won't have that bleak 50% continue to have pain, 20 years later on that. And so, that's the management in a nutshell. And so then the question is, are there some factors that would predict treatment failure? And then the longer you have patellofemoral pain, the number of pain sites, and a lower anterior knee pain score at baseline, which is all these factors, and you might do this, or your physical therapist may do this, so you have objective stuff, kind of predicts treatment failure. Although we don't want to be nihilist, we still would try to treat the patients on there. And so let's recap what we talked about. And so how do we diagnose patellofemoral pain? Retrotellar pain or parapatellar pain. Again, reproduction, when they load that knee joint, you're ruling out everything else, and this is that pain cluster. And so don't forget these 4 categories: a clear overuse, clear muscle deficiency, movement deficit, or hypermobility or hypomobility on that. That's your categories. And then you need to get, this is the physical performance measures, so pain with squatting, then you need to have a scale to see what to do with them. And here's our treatment. Overuse, shut them down for a little bit, maybe tape, because remember we said that worked in the short term, and that's relative rest because that's your overuse patient. Movement deficits, then you're going to do some gait retraining and movement retraining. Weakness, then you're going to work on their weakness on there. And then if you have some hypermobility, hypomobility, that's you're going to work on with your foot orthoses or taping or some mobility exercises. And so it's a little less daunting when you break it up into those categories. And I hope that's helpful for you the next time you see a patellofemoral pain patient on there. And again, if you need, if pictures help you better, so this is multifactorial. You need to think of the hip, the knee, the foot, and the different stresses that you're having there. And those are what you need to work with on that. And so then the next question is, well, geez, can we stop you from ever getting patellofemoral pain syndrome? And to sum this up, they used knee braces, they did some gait retraining, they did some prehabilitation, or they did some foot inserts. And they did okay, but everything had really low quality on there. So I'm not saying don't do it. I'm just saying that there's not great evidence that it's helpful, but it's certainly worth trying and probably needs to be studied a little bit more. And then these things are also helpful for definitely ankle sprains, definitely for ACL tears. So it's not a bad idea to do that. So with that, hopefully we can answer our initial CAQ question. And I'll give you a chance to look at this. So what's the most appropriate next step for that patient that you diagnose with patellofemoral pain syndrome? And taking a look at these choices, I hope that you chose the rehab program design on strength, quads of hip and core, because we would never say this to somebody. Not everybody needs to get an MRI. And remember, we need to work on the hips and the knees together. So with that, I'm going to move on to one of the masqueraders, and that's our Pleika syndrome. So what is it? And so it's vestigial remnants of the different compartments of the knees, and you can have a variety of different pleikas. Is it a true entity? Yes, it definitely is. There was a study that suggested 25 to 50% of all anterior knee pain is from Pleika. I'm not so sure that's true, and I'll talk about that in a second. And the symptoms come from either you tear it or it's repetitively compressed between the patella and the femur, or direct trauma. And remember when I said that there's multiple pleikas, and that study said that maybe 25 or 50% came from Pleika syndrome? That came from an old study in 97 where we were doing more diagnostic scopes, and pleikas are quite prevalent, but they're not all symptomatic. By far and away, the medial pleika is the most symptomatic, but the superior patellar pleika, which you may not feel, is the second most symptomatic, but the most prevalent. And so those will be seen on scope, or maybe even ultrasound. And so, is it really a true entity? I would tell you that there is no doubt that there are patients that truly have this, and you'll know those. And it may be more common in adolescents because they're still kind of growing, but the verdict's out on that. And so they can come in with just this anterior knee pain. The easy one is if they have a true catching or locking or clicking or snapping that you can feel. And remember that giving way is just, pain in the muscle that just kind of gives way. So how do we diagnose it? There's this thing called a Palpation Pleika Test where the examiner is, remember the medial pleika is the most common. They're pushing the patella laterally. They're trying to compress the patella in the medial femoral condyle and squeeze on an extension. And when they flex, then you no longer have that pinch here, and there should be less pain. And the authors report a pretty high sensitivity and specificity on that. And just a reminder, because again, I teach a medical school and we still have to take recertification exams of what sensitivity and specificity are, and really spin and snout are quite helpful for me. So if it's highly specific test, it's probably positive, and a highly sensitive test and it's negative, it's probably not that. And so remember these probably will be on your research, whether for your primary board or for your CAQ. So how do we treat it? And so you can inject it. What's the efficacy? I'm gonna ask you, can you really inject the Pleika? And the answer is yes, but I'll help you with that. And surgery certainly has some efficacy, although there can be regrow, whether that's the Pleika itself or just scar tissue. And so there's a potential to regrow. I have one patient that I'm managing, and she's regrown. They've gone in there twice, and it's just not worth it because they'll continue to get more scar tissue. And so you need to consider that. And so, to do this, now that we have ultrasound, you'd like to do ultrasound guidance into the Pleika. And so can you see a Pleika on ultrasound? The answer is yes. And so this would be something I encourage you to look at to this reference. And this was a study on different positions for the medial Pleika of how to put your transducer. And so medial femoral condyle patella, and this is the Pleika, this is that medial patellofemoral ligament that you'll need to be aware of if you see someone for patellar dislocation. And so it's distinct from that. I want you to be aware of the shape of the femoral condyle here, and it's more concave, and that'll be important in a second. And here's an arthroscopic view. This is flipped, but here's the medial femoral condyle, and here's the Pleika on there. And so yes, you can see that. If you can see it, you can inject it. And this is another example of it. And so this is the medial femoral condyle. This is the patella. Here's the medial patellofemoral ligament, alar fold, and this right here is the Pleika. And on this one, that's definitely symptomatic. It's all ratty and torn up, and so that was removed at surgery. And so if you're looking for these, your transducer position probably matters. And so the medial one is the most common. Here's your transducer. And remember when I showed you the symptomatic ones in the femoral condyle was concave? This is convex, and the authors feel that this is too distal. And you won't see that Pleika. Likewise, this is too proximal because you have the vastus medialis in here. So you're really trying to be right inside of here. So don't be too distal and don't be too proximal, or sweep the area, which would be a general area. Because again, this is what you're looking for, kind of that rounded condyle here. And so I would refer you to that reference. It's a pretty good one on how to hold your transducer or transducer position. And so that's the Pleika. And again, most of the time I would inject those or ask the patient if they would consider surgery. If it was an acutely traumatic one, then I would just kind of calm them down, and hopefully that as the swelling and hematoma resolves, their symptoms resolve. But be aware of it, because you'll never diagnose something that you're unaware of on there. And then finally, with infrapatellar or Hoffa's fat pad syndrome. And so again, here's the fat pad underneath the patellar tendon, and here's a T1 MRI where you see the fat pad here, and here's also a T1 MRI with the fat pad there. And so it's intra-articular, but it's kind of extrasynovial. But what you need to be aware of is it's really enriched with nerve fibers, and so if it's irritated, it really can cause a problem. And one of the questions that we always talk about is the victim or culprit is, so, is it patellofemoral pain, a patellar tendinopathy causing symptoms, or did it start everything? And there was an interesting study that showed that patients who had a larger fat pad at the beginning of, I believe it was a soccer season, went on to develop patellar tendinopathy on there. So the question is it a victim or culprit? And this is the reference for that study. And then patients who have a patella alta are more predisposed to this fat pad syndrome. And it may be a consideration that they may, if this is something recurrent or they're unable to do their sport activity, we may be talking to the surgeons. And so how do you diagnose it? And so one of the ways is this fat pad test. And so here you're palpating the Hoffa's fat pad. I would actually argue you put both fingers around it, so you're actually pinching it and making sure you're not touching the patellar tendon. And then you put them in extension, and that'll squeeze the fat pad there, and that should be symptomatic on there. And so what's the treatment? Correct the offending cause. This is one where taping or bracing can help. And this is a Chopat strap or a counterforce brace. And so that might be a consideration, trying to avoid hyperextension. And then we can inject, or you can discuss surgery and removing the fat pad, but also remember, if you remove it, it was there for a purpose. So is that going to cause a problem? Now, if you inject, what are you going to inject? And so you could do high volume injections, and we're starting to do that more and more for Achilles tendinopathy, patellar tendinopathy, where you would peel the fat pad off right between the patellar tendon and the fat pad, or steroid. And we're moving away from steroid because then you might atrophy that fat pad, and remember, it's there for a purpose. You may want to scar things down with a sclerosing agent. For me, I might try steroids once, and then I'll do dexprolotherapy. But these, again, not great literature on it, not great randomized controlled trials that I'm aware of, but these are nice images of ultrasound long axis and short axis with the fat pad here. And then my final slides are just, if you were going to inject it, how are you going to do that? And so this is a short axis of the patellar tendon. And then you see this, down here. And so they go in plane, and then you can easily see where your needle is. And this is if you were going to peel off the fat pad from patellar tendon, and then out of plane, you can see the needle here. And so that would be an example of this. This is actually an example of a bursitis or a bursopathy. And then again, look at all this coupling gel to make sure you don't compress that. So this is examples of how you would do an injection of the fat pad. This is one of the ways that I do that. And so with that, that will end my talk. And I'll turn over to you, Siobhan. And this is a picture of the Air Force Academy in Colorado Springs. And this is the highest peak, and I didn't want to do it, but my son made me, and I'm happy to get this nice picture. So that will end my talk.
Wonderful. Thank you so much for that talk. That was wonderful. A couple of questions that I had while our audience members think of some. I'm curious about your comment about, I think you were talking about patellofemoral pain and your different hats as a sports medicine provider and your family medicine provider. So when you're functioning as the family medicine provider, how quickly do you have your patients come back?
So for about 4 to 6 weeks, but I will say I intervene a little sooner than that with my nurse or myself, either getting a hold of them telephonically or electronically to see if they're doing the rehab. But I don't really expect much difference in 4 to 6 weeks. If I have someone that I think compliance is an issue, then I'll bring them back sooner, in a week or two, to make sure they knew what I was talking about or got to the therapist. And I don't know about your setting, but that's not always easy in the military setting for numerous different reasons. So 4 to 6 weeks to see on their progress, but I'll check in with them in a week or two to see if they have any questions. How about you?
So I lose in the follow-up quite a bit because physical therapy is a referral, and a lot of our patient population will not, either doesn't have the means, doesn't have the time, doesn't have transportation to get to physical therapy. I provide them home exercises, and I find that it's difficult to have them get motivated enough to do it. So it becomes a matter of suddenly, instead of diagnosing, it becomes an education piece. And so that I think that's a constant struggle that I find with anterior knee pain in the general population. The sports population, not at all. They'll do what it takes to get better and continue to do the sports that they want.
And I may be a little lucky because, we consider every service member, a tactical athlete. And so they've got to pass their physical fitness test. And so maybe that's why we get a little follow-up. The other thing is I can reach out and touch my patients in the service a little bit easier if necessary. And so, maybe slightly different audiences that we have.
Yeah. All right, so guys, in the chat room, there's the link to complete that Survey Monkey. So if you have a minute, please go ahead and do that. Also, in the last few minutes, if you do have questions, feel free to put them in. I have a question, or I wanted to know your experience in learning how to read your own x-rays. I think, with this audience, it's something that I try to really push my fellows to really practice. But in a busy clinical practice, how did you learn how to read your own x-rays?
So I don't know if Dr. O'Connor's on this, if he doesn't watch this, but he was my one of my residency faculty way back in residency. And he was also my faculty director too. And so he's one of the reasons that I needed to read those. So it just became a matter of habit. And then I would say we're blessed in the fellowship that we actually have radiology rounds on there. And then we have pretty good access to our electronic medical records where we can pull up the films. And so I just made it a habit, especially if there was an abnormality, I went and looked and said, what is that abnormality? Because I'd like to see it myself. And then I'll tell you the other trick is if you can have a radiology patient, that's really great if you can have a radiologist as a patient, because they've really been helpful and said, I don't understand this, especially reading MRIs. And so I try to take all the cues I can, and that's how I've done it.
Yeah, that's excellent. Guy, in my experience, I think it was the year that I became an attending. I would have patients get an x-ray and I'd read it in front of them. And I would always say, if there's anything that comes up on the report that we didn't talk about, I will pick up the phone and call you. And by saying those words, it creates more work, but I would call people and say, you know what, I didn't see this. This is what happened. This is what the radiologist saw. Or many times we would call something as a stress fracture because we had the benefit of having that athlete or that patient in front of us to be able to do the clinical exam. So there were times that I would call things and didn't call things that the radiologist did or didn't either. So actually, guys, if you're a fellow this year or a medical student interested in going into sports medicine, take that time because it just creates an added level of learning for both anatomy and your understanding of the biomechanics and how the body works.
And I would also, just like you said, just like we're using ultrasound as a nice teaching tool for patients in the office, point of care, I would show the patients, just like you do, what their abnormalities were and help to explain stuff that didn't make it so mysterious on there too. So no, I absolutely agree.
Exactly. And so we have input from Nathaniel Nye, who says, one thing I do is try to read the film myself before I look at the radiologist report and see if I can make the same calls that the radiologist makes. Yeah, absolutely. And then the other thing is get chummy with your radiologist. Run to their office and say, hey, can you read this with me? That they're invaluable sources of knowledge. So great points.
Was that Nate Nye who said that? He does that? Yeah, that sounds like Nate. So good for him. I actually cheat and look for the report first, but good for Nate.
I'm curious too, with Pleika, before I went to medical school, I was actually a scrub tech and in an ortho practice. And I remember doing millions of plecectomies, and that is so the pendulum has swung completely away. So when you inject a Pleika, how long do you advise that individual to hold out from activity for?
You know, that's interesting. I actually don't tell them that much. So I would say the majority of my treatment would be steroids. And so it's really just a couple of days for the most part. I haven't been using other agents, and I'd be interested to hear what you say, but the reasons I haven't used anything like PRP, I might use Dexprolo depending on the dose on there, but we don't want inflammation. And so that would be the reason I would primarily use steroids, in which case I'm really not that worried about it, except unless you had a different category, you can have traumatic Pleika, in which case if it was trauma that caused that, you know, then that might be somebody I hold back a little bit more. But just like I don't have a problem with my patients coming back to see me, I have a problem with them adhering to not doing something. And most of them want to do too much, and so I have a hard time shutting them down.
For Hafez, you, now that a year and a half ago, diclofenac became over the counter, is that something that you will typically do before an injection, or if there's...
I did use quite a bit of topicals, and I think that it could probably penetrate, you know, outside of patellar tendon, that it probably could do that. I have not tried that. I wouldn't be opposed to it. And so, again, there's kind of two categories for me. I've seen quite a bit where they're traumatic in origin, in which case I don't do anything other than let that thing heal up on there. And then I've seen more mechanical in the younger athletes. I want to put topical stuff all the time, and I'll end up injecting those. And then there's kind of a variety of what I do. You know, it may not be popular, but I still do steroid the first time, but I just don't do repeated steroids on there. And you'll be surprised that, you know, that some it's just kind of one and done, you know, or you get a year's worth of relief on there. But I hadn't tried topical diclofenac, and I may start doing that.
Excellent. You guys, I think that's it. I think you did such a great and thorough job that we have left our audience astounded and having no questions. So I think what we'll do is wrap this up, and thank you so much, Dr. Leggit. Thank you so much. And thank you to everybody who attended tonight. Again, please fill out that Survey Monkey, and thank you for attending.
Good night.
Good night. Take care.